Hello. Hi, Martha.
Good morning, Jay. Well, afternoon. How are you?
Good. How are you?
Good, Jen. I have a huge request.
Yes, ma'am.
I have all the screeners open here with me, but a lot of the times I'm not very successful in sharing it. And
Okay.
not that we will need to share all of those, but do you mind having them open and
No,
in
not at
case
all.
I
Yeah,
have
you just
struggles,
tell
you
me
can help
which
me?
ones if you need some help toggling them. I'll pull up your email right now and have them available. If you just tell me which one to share, I'll be happy to share.
I appreciate that a lot. Thank you.
Happy to do it. Okay, so I have them all open. So if you just tell me the name of them or the number that's on them when you want them open to shared, I'll do it for you, okay?
Great, thank you. I appreciate it. I'm actually already struggling here. Oh, there you go. I got it. So. There's one that I didn't share with you, but I will definitely send it to you at the end of our session. So you can share them with all.
Perfect. We wait just one more minute, Martha, and then we'll get started. Sure. We still have a couple more people logging on, and then we'll get going.
Perfect.
Okay, we can start whenever you're ready, Martha.
Thank you. Welcome, everyone. I hope everybody's having a joyful summer. We have been talking in different meetings that some people are out, others feel just coming back from vacation and just starting connecting. So hopefully this meeting will be recharging for all of you, even though it sounds kind of dry. It's regarding tools and workflows. So we wanted to make something different today, and instead of creating a presentation, we share with all of you all the screeners that we're going to be talking about, and not necessarily that we're going to be explaining the tools, because I think most of you know how to use them, but how they can be incorporated in an integrated behavioral health team, and how clinics can use them. And mainly that, again, as you probably remember, these sessions have some connections. So some of what we're going to be talking today will be connected to the conversation that we had before about billing, about the news about COCM, but also in our next meeting, it will be talking about metrics, how to use this information in a useful way. So again, we're planting the seed for the next session that we're going to have next month. And well, I have here with me, as usual, my partner in crime, Naftali. We're going to be talking about different screeners and workflows. So I'll give the microphone to him so he can start.
Great. Hello, everyone. And you caught me, Martha, when I'm typing a hello in the chat here, just to remind people that the chat is available for us as well. So as we go through, post comments, questions, thoughts, etc. on the chat. So yeah, as Martha said, it's not like terribly exciting necessarily to talk about workflows related to screening tools for behavioral health. But it's actually pretty important to be thoughtful in this area, and that's what we want to encourage you to understand, because a lot of times people, teams underestimate the amount of work, the amount of preparation and protocols needed to drive the successful use of these tools. Many of you may already have experience with these struggles, maybe as you're trying to meet a particular measure. Lots of teams, we're going to talk, one of the tools is a PHQ 9 tool, and lots of clinics now have worked on protocols around them and may even have some metrics that their teams are supposed to meet related to those. And if you do, you know that it's not just as easy as like, oh, we've got this tool, let's just have people fill it out. There's a lot more thought and work that needs to go into effectively making it a useful tool. And the benefit that you get from Martha and I as clinicians, not just as consultants for doing this kind of work, but as clinicians, we can also give you some insight into how helpful or sometimes unhelpful these tools are, right? So we're not just going to sing the praises of all these tools, but we're actually going to give you some ability to have some critical thinking around the use of these tools and things that we've really found to be challenging, as well as helpful.
And
So
Kelly, I just
I'm
want
excited
to,
about the conversation. Yeah.
yeah, I just want to say that if you need me, Jen is going to help us if we need to kind of put it on the screen, any of the screeners. But I think it's more likely that it's more about the conversation and the information we're going to give about the tools. But if you need a screener to be posted on the screen, let me know, and Jen is going to be very grateful of helping us with that.
Okay, great. So Martha, where should we start? What screener do you want to kind of kick us off with?
Why don't we start with the one that it's more common, that maybe a lot of the clinics have, which I think it's the PHQ-9. And I can share a little bit about how we're using it in our clinic, and then you can give a little more information. So this is a screener that I think it's been several years now that it's actually a screen that we very consistently use with all our patients. It's something that in years ago, and I can say probably, I don't know, 7 years ago, it was us, behavioral health, who started, using them with patients when we needed. Then it turned out to be like we were gonna administer it to every single patient we will see. But now it's actually a screener that is given by our medical assistant team, and is given to all the patients, and they check on the chart if they have received the screener or not in the last year. So we're screening people once a year, but now it's not BHC responsibility, but the medical assistant people doing it for us. And of course, those scores are on our medical chart, and we will know if it's a new patient, definitely that's one of the first screeners that we'll be filling out. And if it's an ongoing patient, we make sure that it's at least 1 year that we have those results.
So the PHQ-9 has become sort of a standard tool, but it brings up an interesting concept for you all to think about. And the concept is essentially that there's a difference between a screening tool and an outcome tracking tool, right? And so the PHQ-9 was actually originally developed as a screening tool. That means it was developed to identify patients who are exhibiting symptoms of depression, right? Now, a screening tool is meant to identify the people in a population who meet certain criteria. Typically, we want screening instruments to be very, very sensitive, meaning we want to pick up as many people in the population with that need as possible. And so the PHQ-9 has shown itself to be a pretty decent screening tool. It picks up a good number of those folks in the population. And I'm just going to pause for a second. Martha, I think your audio is a little bit, there's something in the background, so maybe if you go on mute. that might help a little bit. Maybe it's not, there we go. All right, that's a lot better. So it's pretty good as a screening tool because it picks up on the people in the population who have those needs. However, there's also a function that it has obtained subsequently, which there's some, I would say, controversy about in the clinical community, which is how good is it as an actually outcomes tracking tool? In other words, so the PHQ-9, does it do a good job of tracking if someone is getting better or if someone is getting worse? Is it an accurate way of depicting progress, right? And, clinically, it's a little bit hit or miss, which has resulted in the fact that a lot of clinicians don't actively use the PHQ-9 actively in sessions because it's not as helpful a feedback tool as I think we've thought about it in the past. And that makes some sense clinically if you think about it, because it's very rare, especially these days, that you have someone who just kind of has a pure or classic depression. You have folks who are experiencing symptoms of depression, but with a mix of other constellation of potential symptoms, maybe some trauma, maybe some anxiety, maybe some substance issues, etc. And as we set functional targets for that patient in a primary care setting, especially, the PHQ-9 may not serve as a very good proxy of whether that patient is improving. So, for example, I've had the experience many times as a clinician where a patient may have gone from a score of 19 on the PHQ-9 to a score of 17, which is pretty nominal. But from a clinical standpoint, functional standpoint, they've improved significantly. And so, in that situation, of course, I'm not going to say, well, they're still depressed, they're still, struggling. Well, they may still have symptoms, but they're actually improving in their outlook and their outcome. And that's just important for you to understand that not all tools are super awesome at tracking outcomes. Another opposite example is with certain populations, like with Latino patients. I often have the experience where a person will have a high PHQ-9 score at the outset. Maybe they have a 21, a score of 21, and 2 weeks later when I see them, they have a score of 7. It's like, well, did they really get that better in 2 weeks? No, there's some cultural factors that load onto that, that sort of discrepancy in the score. So just important to understand those two concepts, right? Some tools are very good at screening, that is capturing the identified population, and some tools are better at tracking outcomes. Now, that doesn't mean that I'm discouraging you from necessarily using PHQ-9 at outcomes. If you're using the COCM model, for example, you are very much relying on the PHQ-9 for your outcomes. That's what's going to be driving a lot of the decision making. But even in that situation, it's still always up to the PCP and the care manager and the consulting psychiatrist as to what are the patient's functional goals, irrespective of the PHQ-9 score drops. The PHQ-9 in that situation serves as a potential trigger, a way to keep an eye on the affected population and the individual patients who may need additional intervention or medication adjustment, et cetera. So using the PHQ-9 sort of as a proxy for good clinical outcomes, but don't confuse good clinical outcomes with, scores necessarily on tracking instruments that really, in essence, weren't originally designed as tracking instruments.
I just want to double check. It's my audio hearing well right now?
Yes,
Can you guys hear me well? Okay.
That's better.
So I just want to share something funny that happened. So my daughter used her headphones and it connected to my computer. So she was in her room hearing the meeting, and I'm like, what's happening here? The beauty of vacation and having the kids at home. Sorry, guys. I think it's all under control now.
All right. So So that's a little bit on the PHQ-9. Now, another key feature, and I want to ask you about this, Martha, because I'm not sure what the protocol is at Access right now. But a lot of clinics will use as a sort of an initial screener, PHQ-2 or a PHQ-3, which are just shortened versions of the PHQ-9 at Access. Are they doing that these days?
No, that's a really good question. So one of the things that we have found out is that even those two questions were not really helpful. And then we were going to actually do, if they were come up positive, tell the patient to fill out the longer form, right? So in one of actually the forms that I share with you guys is actually a PHQ-9 and the GAD-7. And that's the one that we are using right now in the clinic. So we are not using the short version because we find out it was not very helpful as a giving information to us. And right now I can say we're not doing COCM, but we are keeping track of those patients who came up high in a register and giving them a call back. So we are having that, we have that system in place just as a tracking tool and data. And we find out again that the short version was not really helping us in that sense. So at this point, we are not.
And that's important to understand because that's pretty much the national trend. So about a couple of years ago, a lot of clinics were doing PHQ-2s and they were doing verbal administrations of the PHQ-2s. So they oftentimes it would be the medical assistant who would be asking the patient when they're rooming the patient, you know, the two most salient questions in the PHQ-9. But as Martha said, it didn't turn out to be a time saver, first of all, because if a patient came out positive, you're going to do the other 7 questions anyway, and it doesn't take that much time to do the other 7 in a row. But the other thing, and this is again another take-home point when you think about using screeners and these tools, is that it added work to the medical assistants, work that was difficult to do, so it didn't happen all the time across clinics, so compliance became an issue. And a lot of clinics implemented this without training their staff on the tools itself, so that you had medical assistants administering verbally a tool that was not standardized for verbal administration, and administering it in such a way that was leading patients towards certain answers. So for example, and I've observed this personally when I shadow clinicians sometimes, or not clinicians, shadowing some of these administrations where a medical assistant would ask, you're not feeling sad, hopeless, or depressed much in the last 7 days, right? Right. So that's obviously a leading way of asking that question that's going to elicit a certain response. So if you're not training your staff on how to best administer, you're going to not get the results you want out of a screening tool. So the bottom line is, at this point, most clinics are not doing PHQ-2 administration or PHQ-3 administration. They're doing the full thing. And also, like you noted, Martha, very importantly, a few years ago, clinics were trying to administer it to everyone who walked through their doors at any point. And now it is more standard to use it in a targeted fashion where you're doing it at annual well visits or at least once per year for the patient. And then using it at a either 2 to 4 week interval with the portion of patients that are already identified with a diagnosis of depression or anxiety.
We have a question here in the chat. Anna's asking, with full PHQ-9, are you referring to PCP clinics of just behavioral health clinics? I don't know if I'm understanding this correctly.
With full PH, are you referring to PCP clinics? Or,
I'm talking about a federal health center, which, you know, there's PCPs and we have behavioral health inside that clinic. So it's not just behavioral health. It's not just PCP.
Yeah, I think Anne might be actually, I think she might have typed of, but it might be or PCP clinics or just behavioral health clinics. And no, so yeah, so as you're describing, we're talking about primary care clinics.
Correct.
Here.
Yeah.
All right, so anything else we need to kind of cover, Martha, you think, with PHQ-9? We didn't talk about the GAD-7, but in a way, the GAD-7 and the PHQ-9 are sort of married these days. So for those of you who may not be clinicians, don't know, the GAD-7 is just a 7-item screener that you have in your email. That's for, it's a broad measure of anxiety, essentially. So it's going to pick up on folks who may have some panic disorder, may have some generalized anxiety disorder, or just have like a generalized adjustment reaction with anxiety.
Yeah, so no, I just want to highlight that I think it's important that when we talk about workflows, using these screeners and creating a workflow, that it's important that we think about how our clinic or our site is working and what makes more sense to introduce the screener in a way that, like the word says, it would like a flow and not interrupt the flow, since when the patient, comes to the clinic and is being seeing the patient. And sometimes that will means that you have to try out different things. Like I said, in the beginning, we were us, PhDs, administrating these tools. Then we realized it will make more sense if medical assistants will do that. And in that learning curve, we realized it was important to train our staff as well. So if you are thinking about creating a workflow, try to check how your clinic works and what actually will make things easier in your clinic, and that you might be trying different things until you figure out what's the best, again, workflow for your clinic. So Naftali, I want to ask you, if someone is thinking, or they're already actually using the PHQ-9, and they really want to standardize this as a workflow, what would be the best thing to do?
Yeah, so I think one of the first things is to do a flow analysis, like you talked about, is to really map out and actually practice, like, how would this work, even down to certain specific details, like who's in charge of refilling the paper screens? This is assuming that you're doing a paper version, right? Like who's in charge of making sure that we have enough PHQ-9s at each of the care team stations, right? Who's got that job? Who's in charge, and how would they know? How would they know that it is time for a PHQ-9 administration? What would be the easiest way for that to happen, right? Because you don't want medical assistants, for example, fishing through a chart to figure out if this patient needs a PHQ-9, right? Or a provider for that matter. You want something that feels a lot more automated, right? And then I think it's important to involve your people. Like if you're going to involve a medical assistant in the process, it's not really fair or helpful if you just drop a protocol on them and say, hey, here's what we're doing now. You want to involve a key, maybe medical assistant leader of the team and say, hey, here's what we're thinking flow-wise. We think that at annual well visits, while you're doing some of these other questions, you can also give the patient a PHQ-9. And then at the end of the visit, you will be responsible for going in and entering the score into the EHR. How does that sound to you? Do you think that works? Do you think we could get as close to 100% compliance as possible, right? Working that flow is absolutely crucial to making sure that you develop a protocol that's actually going to work. And then the last piece here, so you work the flow through, you get team members on board to make sure that they understand and have buy-in and are contributing to that flow. And then you train. You must train. You must help people understand, why are we doing this? How do we respond to a positive, for example, right? Let's say you get a PHQ-9, the last question, question 9, is a question on suicide. So if they mark a 3 on that question, the medical assistant is the first person, potentially, again, assuming the medical assistant is doing this part of the process, they could be the first person to see that a patient is actively considering suicide. And so you want them to be trained to have an adequate first response, right? How do they respond to that? How do they show empathy? openness, but also no boundaries, and no, it's not their job to fix, not their job to intervene. It's only their job to be empathetic with the patient, thank the patient for the information, and then hand off and alert the provider to the screen to make sure that they check that last question and discuss with the patient, right? So I think if you're able to hit those marks, you have a better chance of making good use of the screen, as opposed to far too often what I've seen is the PHQ-9 used as something to check a box, right? Okay, we did it, it's done, we checked the box, but it really doesn't have much clinical utility unless you really work it through what you're intending it to do.
And it's really interesting what you have just described, because you just described like at least 9 steps, right? That
Yep.
people are not really think about it when very mindfully they're saying, okay, we're gonna start this. What's the start point? What's the end point? And there's different steps to do that. And the more unified that is, the easier it will be for all the clinic. And again, it creates a flow that is not actually interrupting the clinic flow. So I think it's important to be mindful as how you plan that. With that, I want to share with all of you actually something that, again, we discovered in the clinic when we were starting with the ADHD screeners. So we started with the ADHD screeners Vanderbilt for kids. And one of the things that we were doing back on the days was giving that paper copy to the parents to fill it out, the Vanderbilt, and then have the paper copy for them to bring to the teachers. Well, we realized our intention was great, but that flow was awful because we were receiving actually the results. Maybe we will get the results from the parents because they will stay there filling it out even though it's long. But a lot of the times we will never receive the teacher results. And that was just affecting, our interaction with the patient, the parents getting frustrated, school maybe calling us. So it was not a flow that was allowing us to give the best serve to the kid. So one of the things that we came up and it actually was a big turning point, it's to submit those, it was part of creating that workflow, it was to submit the Vanderbilt to teachers via email. So we will get the release of information for parents in the session. We will know the school and the name of the teacher, and then we will send that to the teacher via email. And we will get them at least in 2 or 3 days, right? Because the teachers will get that email. It was a tool that teachers were using often, their computers, their email, and they were replying to us. We will get the results. And then on the next visit for the child, we will be able to compare the parents' results with the teacher results and figure out what was going to be the plan for that kid. So again, these are things that takes time to figure out, but that it's important to start, identifying where are we getting stuck, what things we can get solved. And we share with you both the Vanderbilt in English and Spanish, but also now lately we realized we needed to create a workflow for ADHD for adults, which before it was not such a need, but in the last year or so, we realized there were a lot of adults coming, requesting, being positive in ADHD, and providers not feeling comfortable just starting, a stimulant at that moment. So BHC realized the need, and we needed to create a flow for adult ADHD. And again, we shared those tools with you guys and specific instructions that we needed to give the adult about who was going to fill out that information. And then in order for the provider to feel comfortable to start a stimulant, if they have never in their medical record had any presence of ADHD, to be something to be considered. And it's always going to be a work together with the behavioral health team, because it's not just about the medication, but also helping the patient with some behavioral tools that they needed to introduce in their life. So just sharing with you guys how with time, we have to learn and adjust that workflow for the ADHD screeners.
Yeah, and that brings up a slew of important points there that you just threw in. So one of the points is that automating your processes as much as possible is super crucial. As Martha said before, what we want to do is introduce these screeners in ways and tools in ways that don't interrupt clinic flow. and that don't interrupt clinical care delivery. So the problem that Martha talked about was interrupting both, right? Because we had to have the parents fill out this form there, and then we also had to give them paper copies of the teacher form, give them instructions, and then the parent would have to go to the school, get them filled out, hopefully get them back, bringing back to the next session. By that point, sometimes 2 to 4 weeks has already transpired. And then, as Martha said, a lot of times the patients would come back and they wouldn't have the teacher forms. In which case, then we're back to square one. We don't have all the information we need. Same thing with adults, right? So automating your processes is important. So that was transformative when we started sending links via email. And in our case, the links went straight to a third-party company that had a HIPAA-compliant website that we could use for the teachers to fill out their information confidentially and securely. And then we'd get that automatically on our end. And it changed the nature of our ability to treat quickly, right? So patient would come in, within 2 or 3 days, we'd have the response with very little work on our part. And then we could cue the primary care provider related to whether we're recommending medication or not. And then by the following week, we might even, or the following 2 weeks, when we see the patient back, we might even be able to have sent a prescription over the, electronically to the pharmacy, get care started, and just move care along a lot faster. Now, these days, there's a lot more companies out there than there were even when we started this process in the late 2000s. There's a lot of companies out there that will do this kind of automation for you. Now there's a lot of companies that will even do it with regard to sending your patient text messages. So if you have accurate cell numbers, you can send tools to your patients via text, and they can click a link, open it up, fill the information out, and it'll come back automatically to you. So if any of you are interested in getting connected with any vendors like that, CFHA has a list. We don't get we're no kickbacks here or anything shady like that. We don't promote any company over another, but we do like to connect folks to good solutions when they're out there. So we can definitely connect that. But automation is a big piece of this because it's too much to ask. Even with automation, there's still some additional work. So for example, Martha, in your situation, those scores come back, but they don't come straight back into the EHR, do they?
Correct. They don't come back straight to it. So somebody will be monitoring them and then reviewing them and putting them on the chart as a medical encounter together with the results of the parents or whatever the notes are. But it's a manual thing that happens, yes, at this point.
Yeah, that's right. So there's still work as far as those workflows go to do. Now, the other key point I wanted to ask you about, Martha, is about the adult ADHD protocol, because we've been talking about the mechanics of, survey administration, et cetera. But there's also the clinical component, the clinical decision-making that goes with it. That's part of the protocol. And that's especially important for like adults in ADHD. So can you talk a little bit about how BHCs help providers make decisions with adults with ADHD, sure, particularly when there's complicating factors like, substance abuse involved?
Sure. So I want to say that the screeners that we're using and there's like a interview, I think it's called, for adult ADHD that we have and we provide, is just a piece of the puzzle, right? Even though that comes really positive, at the end of the day, we're going to make the decision together with the provider with all the information we have about the sessions we have made with the patient, what we have, discovered with all what the patient has said to us, what we have on the screeners, and then the conversation with the provider. So I cannot tell you that we give the same outcome to everyone. It's a very individualized process depending on the patient. And like I said, the screeners are just like one piece of the puzzle. The other piece will be what the providers think, the health concerns we have about the patient, all the information we obtain on the sessions. So it's really, completing the puzzle in order to figure out if this is an appropriate patient for a stimulant or not. And remember our role as a consultants with the providers. Does the provider feel comfortable doing that or not? Luckily, where we are located, we have a consultant psychiatry that in those cases, when we don't feel quite sure, it's a really gray area and the provider doesn't feel comfortable, we have the consultant psychiatry to jump her in our team of making the decision for that particular patient. So it's not a straight answer, and it's really a team effort work at the end of the day when we realize, yes, we can give medication to this adult or not.
Yeah, and by protocol though, all adult ADHD patients have to go through the BHCs.
Yes.
So that makes it standardized so that the provider then has an out at that first visit. If a patient comes in demanding stimulants, they say, well, look, this is at our clinic, the way we do this is that in order to accurately make an accurate diagnosis and assessment of what's going to be helpful, we have our behavioral health consultants who are part of that process. And then they're involved in part of the care, as soon as possible.
The other rule of thumb is that we will not provide the medication in that first visit. At least they have to engage with BHC for 3 sessions at least. And what we find out is that they don't come back sometimes. So that means that maybe the need for that medication had another underground reason instead of really, struggling with their attention.
Yeah, I forgot that there was also that 3-session kind of rule, and we instituted that because we wanted to suss out some of the patients who maybe did have some ulterior motives for seeking stimulants, right? Diversion, for example. Yeah.
Another story that I can share about other screeners, and that's jumping into more of the substance abuse screeners like the SPRIT and the audit. It's again, these were screeners that years ago, it was just BHC using them when we felt there was a patient that was using alcohol or drugs, or the providers, give us a heads up on that. But it was not very consistent that we were doing it. With time, we realized that we were missing patients, missing that in their minds, they didn't have an alcohol or drug problem. So they were not reporting that because they didn't have that in the radar, but that it was important to screen those patients in general, right? So, and then that will give us the opportunity a lot of the times to provide psychoeducation for maybe not knowing that actually drinking 2 drinks every day might be having a problem, right? So we find out that when we standardize, again, the workflow for these screeners, and we did it very similar to the PHQ-9, in which it's the medical assistant who will provide those screeners, and we will do it in very tactical times, like every 6 months, or depending if someone was high, we will, definitely follow up more closely. But we realized we were missing a lot of people who were struggling with alcohol that we didn't know. And we find ourselves providing a lot of psychoeducation about the use, particularly of alcohol, and again, in a preventing stage, right? So when you do that education and you're able to capture that there's a possible problem and you're able to educate the patient, we're getting ahead of the problem. So it was a great life changer for just providing good care to our patients when we introduce the alcohol and drug use screeners as a standardized thing since they start in the clinic.
And just to clarify, at your clinic, Martha, what's the interval? Is it done annually?
Yes, at this point it's annually, unless again, if it's high or it's a different, but usually it's annually.
Yeah. So just to familiarize those of you again who are not clinicians, the audit and the DAST are, as Martha described, tools that are screeners. And in this case, they really are screeners. They're not really used at all for kind of outcomes tracking necessarily. They help ask questions about alcohol use and substance abuse. So the audit is alcohol, the DAST is more oriented towards other substances. And the key point from Martha's comment there is that if you're going to effectively target a population with a condition like substance abuse, episodic screening is not going to be as helpful as a planned strategy for screening. But again, as we've pointed out, you have to find an interval of screening that makes sense for your flow, for your population, and for what you're trying to accomplish. So, you know, annually at well visits, or when a provider is potentially identifying a potential issue but wants more information, is typically the way most health centers use that screener. Now, if I was working at a homeless clinic, for example, I would probably use that screener at every visit, right? But at a standard FQHC, typically annual is the usual administration time, unless there's an identified concern, in which case it's used to screen out and suss out whether that problem is an issue that may need intervention.
So Michelle, to answer your question, yes, it's annually, not at every visit. But let's say we have a patient who started in January 1st, right? And we did the screener of the year. And then 7 months after, they describe a big change in their life, a stressor, losing a partner or something. Well, we know that even though we did the screener in January, this is an event that might justify to administer the PHQ-9 again. So annually, it's the answer, or as needed when we feel it's important to kind of screen again.
Or if you're in COCM, you're going to be doing this almost every contact. The smallest window of time, if you're operating the COCM model, is going to be 2 weeks, because the screener itself asks about the last 2 weeks. But typically at almost every contact in COCM, you're re-administering the PHQ-9 or remeasuring it. If you're not doing COCM, but you're kind of doing something like COCM, and you're trying to treat a population with depression or anxiety, you want to at least at a minimum administer the PHQ-9 about once a month. That's about through the episode of care for that patient. That could be a general target for you. But in pure COCM, you're doing it almost every contact, which in the beginning especially is more like on average every 2 weeks.
Now, there's actually rating scale that I didn't share in our email, but I'm going to do as we finish this meeting today. And I'm going to give Neftali a little bit of time for him to talk about it. Well, I'll try to share my screen, which hopefully I'll be successful. I will always say I don't use Teams just with you guys. So every time I need to share things, I shake inside of me. So hopefully I'll be successful to share that while Neftali talks a little bit about the outcome rating scale.
Yeah. So, you know, thus far, the tools that we've shown you are screening tools, right? And the PHQ-9 is a screening tool that's been kind of like gerrymandered to be an outcome tracking tool. But what we don't have a lot of actually in primary care, and this is actually an important research question, are really great outcome tracking tools. And that makes sense if you think about primary care, because primary care is so broad, right? You think about the number of things that come into primary care. If you were like to, in a sense, justify primary care as a whole, you probably couldn't come up with one outcome tool for it, because you have one visit that's for immunizations, one for a well visit, one for chronic back pain, one for diabetes, right? Those don't all share the same outcomes, right? So over the years, different clinics have used different proxies like quality of life measures to see if interventions in primary care are effective at improving quality of life, for example. Those haven't gained a whole lot of traction because clinically they don't tend to be very useful. They're not sort of tied in very tightly with the actual work going on. Now, more recently, a randomized control trial was done using this tool. And this is a tool that I'm excited about because it does do a good job of tracking outcomes, particularly for behavioral interventions. And the RCT was actually performed with patients. I believe it was in several FQHC sites. And what I found was that the tool was really, really helpful in tracking improvement over time in patients who had seen behavioral health in these primary care clinics. So the tool is called the Outcome Rating Scales. And if you look at the instructions there, there's actually a version for kids as well that is picture-based. But it's a super fast, super easy tool to administer, which is another key point we haven't highlighted quite yet. Any tool you administer in primary care has got to be super quick, and super quick typically means 10 or 12 questions or less. Once you get anything above that, you really get into something that gets onerous for the patient and also for the clinic flow in a primary care setting. So the tool basically asks the person to mark on the line what their particular state has been, what their feeling state has been in each of these particular areas. So they literally just mark a line. So very low literacy level needed for this, very little maneuvering. Most patients finish this in about 10 seconds, 10, 15 seconds or so. And so the way it's scored is that the clinician after the fact actually measures, and I've gotten good because I use this tool. I've gotten good where I can eyeball the line. The lines are 10 centimeters long, and you score it based on the number of centimeters. So if the mark is over here on the closer to the high end side, it's going to be like an 8 or 9 or 7 in that area. That's the number, and you add those up, and that is your score. And then there's a sort of a cutoff score that denotes patients who are potentially needing some additional assistance and who are maybe struggling, and folks who are doing better, essentially. And what I like about it, as well as an outcome tool, is that it's really patient-centric. So it's really related to the goals and values that the patient has about their own life. So how they're doing personally, how they're relating to others around them, whether they're effectively engaging social aspects of their life, and just sort of a generic sense of how they're doing overall. So this is a quick and dirty tool. There is a company, again, we don't get any kickback from all this, but there's a company that actually owns the trademark on this tool. You don't have to pay the company just to use the tool as an individual clinician. I don't pay the company. But they do have a system where you can have this tool on an iPad and give it to the patient in clinic, and they just mark it there, and it automatically scores it and stores it in a registry. So you can get pretty fancy smancy if you want to do that, do something like that to that level. So this is an example of what a tracking tool is. It is not the only tracking tool out there. As I said, there are quality of life measures that are out there. There's something called the Duke Health Profile, which is another functionality-based outcome tracking tool that some clinics use. The function, again, of tracking tools is to track how patients are doing and to embed your care in what's called measurement-based care. That is the idea that you are actively measuring where the patient is at in the course of their care, and that you are then making adjustments based on that data around how they're doing. So for example, if I get an ORS score, and this has happened, where I'm talking with the patient as a clinician, I think, oh, they're not doing too bad. They're doing okay. They give me the ORS towards the end of our visit, and I look at it, I'm like, oh, this is a ORS with a score of 25. That's not how I thought the patient was actually doing. And that helps me then to rejigger and provides potentially some more focused support for that patient. Maybe talk to the patient about goals. Maybe we're not focusing on the right goals. Maybe there's something about the course of care that needs to be changed. Maybe medication's not working well or effectively. So, so that's what measurement-based care is. It's a way of basing the care you're providing on data-based feedback, right? It's similar to what you get with a CLCM model, where you're continually getting feedback from the PHQ-9 as a tool to guide whether you are making progress or not making progress with certain patients. So that's an example.
Yeah, so and I will definitely share that after our meeting. And I didn't want to answer on the chat this question because I thought it was important to bring it out loud and for all of us to talk about it. So Leslie mentioned thoughts about an organization that identifies as a zero suicide organization, a primary care clinic, who is committed to screening for suicide, using the PHQ-9 to screen and then follow up with CCRs to further assess suicidality if question 9 on the PHQ-9 is answered positively. Following this workflow at every patient contact, but not sooner than every 2 weeks?
Yes, so you're talking about the Columbia suicide screening tool. So yes, I think that tool is best used in a targeted fashion for those kinds of situations. However, I will say that in most cases, what I recommend is allowing some clinician judgment at play. Now, this depends on the level of sort of sophistication of your behavioral health team, right? So there's some variability there. With a lot of young providers who maybe don't have as much experience, I might make it a protocol. In other words, I might make it standard, just like you put it there. You know, PHQ-9 screen, pressure 9 is positive, automatically administer the Columbia screen. However, in most situations where you have more experienced providers or more experienced team, it's more patient friendly to have the provider do some verbal investigation around question 9, because there's lots of times that question 9 is a 2 or 3. And what the patient means by that doesn't necessitate further assessment or evaluation. So it would be superfluous and in fact counterproductive to administer the Columbia suicide screen in that situation. It would be distracting to the patient's goals. So I would suggest allowing for some clinician feedback on that. And in fact, this is another good indication of training, because you should never just say, we're going to start screening patients with the Columbia suicide screen if you haven't trained your staff around suicide assessment, and suicide sensitive conversations. And I know the folks that developed the Columbia screen would say the same thing, that's what a zero suicide organization actually does. Hopefully that's helpful. And if not, Leslie, speak up. Or Alicia, yeah.
Yeah, thank you. Great. Well, this is the screeners that we had ready, that we prepared for all of you. And just, we thought it would be helpful to, well, of course, share them all with you, but also just share with you guys our workflows, our experiences, what we have discovered throughout the years. And like I said, that doesn't mean that this is exactly the right way to do it, but that at least it will open the idea of you start to think about how you can map out workflow in your own clinic, what makes more sense, what will facilitate things to the clinic, to the providers. Naftali highlighted an important thing to always include your team when you are gonna start working with a screener. The more you work as a team and you get everybody's input, you can get a better, ideas or suggestions as to how to do that workflow more smoothly. And it's also important that the clinic knows, and in this case, in general, the staff, what are you doing with your patients? What screeners they're getting? Why you're doing it? why they're helpful, what information it's actually being captured because it's important to keep track. So all those questions are important for the staff to know, not just providers, not just BHCs, but support staff, even sometimes the front door staff, the front desk staff. So I hope it hasn't been that dry.
Well, and I also want to end on a positive note, because I hope you haven't felt negatively about all the work that's entailed with implementing these screeners. We don't want to discourage you from using screeners. We do want to discourage you from using screeners and outcome tools recklessly, or mindlessly, right? That's what we've seen far too often. Tools are administered, but then they're not really used, right? And that's not really accomplishing anything other than checking a box and saying we did it, we screened it, right? And so you just want to be mindful about, as Martha said, why you're using the tool, what you're hoping to get out of that tool, who's going to help manage the process around using that tool. And in fact, we didn't even mention one piece of the puzzle, which is your quality person, right? So the quality person at your organization, or whoever's in charge of sort of the population-based data analysis at your organization, really should have some sense of what their role is with respect to what this data that you're collecting is, right? So if you're collecting data on your audit and DAST, your quality person should have a clear sense of what is it I should be reporting on, and what would be most helpful to our clinical teams to get as far as feedback on this. Are we just reporting on the prevalence rate, right? Are we reporting on prevalence rate for certain age groups or certain subpopulations? Do our teams need panel-based information fed back to them around how many patients they have on their panel, or which are the patients on their panel that have high PHQ-9 scores in a given quarter, right? So if you're thoughtful about these instruments, they can be really useful and helpful. If you don't put a lot of thought into it, it becomes just a perfunctory exercise that everyone team hates because it doesn't really accomplish anything effective. So with some thought, go ahead and do it. Another little tidbit, don't do a bunch all at once.
Yeah.
Each of these changes take their own time to support and change. So what you want to do is take one instrument, one tool at a time, implement, learn, run a PDSA cycle on it so you can learn as an organization about how that went. And then next time when you get to the next tool, you have another opportunity to implement the next tool in an effective fashion based on your learnings from that first time.
Yeah, but if you want to know more about, well, how these tools can be effective in regards to what Neftali was saying about quality and metrics, don't miss the next episode with Martha and Neftali next month.
All right. Yeah, we're going to talk metrics next month. We'll show you a little sample dashboard that we use with clinics and talk through how you can track some important metrics, not just related to these tools, but also related to your program metrics.
Ooh, I'm excited
All
about
right.
that because we are going to track some metrics for groups through this project. So I'm looking forward to the next session. Thank you, guys.
All right. Thanks, everyone.
Bye.
Take care, everybody. Thank you.